All right. Good morning, everybody. My name is Mary Leonard. I'm chair of the Department of Pediatrics, and it's my great pleasure to welcome you to Pediatric Grand Rounds. We have great energy in this room. If anybody's upstairs and they want to come down, we've got breakfast. I know we have a lot of people online. So my pleasure this morning to welcome our guest speaker. But first, I just want to draw your attention to the incredible lineup we have in the next few weeks. We were just talking at dinner last night about what it's like when Peter Hotez is in town. It's quite an event, and next week I'm sure will be just like that. And then our own John Klein is going to speak on adolescent health and well-being, opportunities and challenges. And then just drawing your attention on the left here, the usual housekeeping for MOC and CME credit. All right. And then our land acknowledgement. We recognize that Stanford sits on the ancestral land of the Muwekma Ohlone tribe. The land was and continues to be of great importance to the Ohlone people. Consistent with our values of community and inclusion, we have a responsibility to acknowledge, honor, and make visible the university's relationship to Native peoples. I want to make sure everyone has on their calendar this inaugural Stanford Medicine Children's Health Research Community event, where we're going to, in this room, bring together all the folks that help support clinical research across the enterprise. Really good opportunity to learn about all the new services available through the Community Engaged Office of Community Engaged Research, the Quantitative Sciences Unit, the Clinical Research Support Office, and more. So please join us for that event. And now we're turning to the Crowley lecture, and you can see the very distinguished lineup, Dr. Cheng, of the people who have given this lecture, some good friends I know of you personally. So this is a lectureship where we alternate with surgery. So you can probably figure out which years were the pediatrics years. But let me just tell you very briefly about Dr. Lawrence Crowley. He was a surgeon who really is widely credited as one of the driving forces that led to the building of the Lucile Packard Children's Hospital. He's described as a rare physician who enjoyed medical administration and excelled at it. And I would say today's guest speaker is the same. Among his many distinguished leadership roles, he was dean at the University of Wisconsin, but it was really the work here that was so impactful. He had all sorts of administrative positions here in the 70s. And then he became the associate dean for planning and led the medical school's long-range academic plan in the 70s. In the 80s, he resigned from that VP position, but really at that point shifted his focus to the Children's Hospital and helping to create it. So he worked very much side by side with Lucile Packard to envision a new children's hospital for the region. His conviction was that the Children's Hospital should be physically connected to Stanford Hospital, so patient care, teaching, and research would benefit by sharing resources and services. And the vision was that this new hospital would be a standalone children's facility that would consolidate all of children's clinical services. And Susan Orr, who is Lucile Packard's daughter, wrote, they spent a lot of time together designing the building, traveling all around the country, looking at other children's hospitals and incorporating the best ideas that they found. And without his leadership, we would not have the world-class children's hospital that we have today. He then was chair of the board of directors of our children's hospital for many years. And then it was the board of the Children's Hospital that created this lectureship in his honor. So turning to Dr. Cheng. Dr. Cheng is the B.K. Ratchford Professor and Chair of Pediatrics for the University of Cincinnati College of Medicine, Director of Cincinnati Children's Research Foundation, and Chief Medical Officer at Cincinnati Children's. Her clinical work, teaching, research, and advocacy focus on child, adolescent, and family perspectives on improving health, as well as community integrated models to interrupt the intergenerational cycle of disadvantage and innovation for excellent and equitable health outcomes. She was previously chair of PEDS and pediatrician in chief at Johns Hopkins University. But very importantly, for 15 years, she co-led the NIH-funded DC Baltimore Research Center on Child Health Disparities and co-led the establishment of 2 clinical and research innovation centers at Johns Hopkins, the Rails Center on the Integration of Health and Education and the Johns Hopkins Center for Salud Health and Opportunity for Latinos. She's the author of hundreds of publications. She's been the PI on numerous federal and foundation grants, including grants from the NICHD, the CDC, Maternal and Child Health Bureau, the National Institute on Minority Health and Health Disparities, and the Robert Wood Johnson Foundation. I could go on, and Tina, for weeks I've been telling people that you are coming and that it's a very exciting event for us and for all of your wonderful work in advocacy and health equity. And so welcome.
Thanks so much, Mary. And it's really an honor to be here among so many friends and to talk about, what's most important, which is the arc of progress in child health, post-pandemic pediatrics, and really an honor also to remember Dr. Crowley. It was talk today about where we are now post pediatrics and how we really need to be leaders in making sure that children are at the center of what we do in healthcare, but in their health in general. So I have no disclosures except that I do serve as a consulting editor of Pediatric Clinics of North America, and wanted to talk a little bit about great achievements in pediatrics in the last 40 years. And we have come a long way in pediatrics. Drivers of the future of pediatrics post-pandemic, patient and family needs, scientific advancements, and health system transformation, which I think should be driving where the future is going. Windows of opportunity, because I think we do really have windows of opportunity towards excellent and equitable outcomes being our goal, and how we can really lead the way. So I like to often start with this Time magazine article that said that this baby could live to be 142 years old. Not sure about that, but it said that we do live in extraordinary times. Thanks to medical and scientific advances that even a generation ago would have sounded like science fiction, an American born today has a projected average lifespan 20 full years longer than one born in 1925. Pretty tremendous, and really thanks to all the work of people in this room and more. And I led a campaign for the American Academy of Pediatrics on the 7 great achievements in pediatric research in the last 40 years. I think we forget about these achievements. Preventing disease with immunizations, tremendous. Reducing sudden infant death from back to sleep, curing a common childhood cancer. We know ALL was a death sentence 40 years ago, now mostly cured. Saving premature babies with surfactant, preventing HIV maternal transmission with antiretrovirals, increasing life expectancy for children with chronic disease. 40 years ago, CF and sickle cell disease, life expectancy was in the teens. It's now 40, 50 years old. Pretty tremendous. Saving lives with car seats and seatbelts. And these are just a few. And people come up to me and say, what about other discoveries? And there are so many more. And I think that we just really need to make sure that we don't forget the great advances that have been made. My favorite is a primary care pediatrician that said, what about the invention of Miralax for constipation? So the translational science spectrum, I think, is a lot of this, and it's not just basic research, it's basic research, preclinical, clinical research, clinical implementation, and public health that really has led to the increase in life expectancy that we see today. And this is the NCATS translational science spectrum. And I think we should be really proud of the progress that it's been made. Judith Palfrey and Dr. Richmond really talked about children, about the trends in pediatric morbidity. Where have we been? In the 1900s, it was called the era of pediatric nosology. We didn't know very much about pathophysiology. It was a time of infectious disease epidemics, poor nutrition, few cures for chronic disease, high infant mortality, and really not very much focus on children at all. But then we began to understand pathophysiology. It was an era of laboratory investigation, studies of nutrition, discovery of sulfonamides, then followed by an era of pediatric therapy, more vaccines, more antibiotics, subspecialty knowledge. In some ways, we can say we're still in that era. Then the era of child development in the 70s and the 90s, where guiding psychosocial development was thought to be equally important. New morbidities were talked about then, and high technology care. And now they say that we're in the era of bioenvironmental interface, new epidemics, obesity, family stress, mental and behavioral health disorders, global community concerns, not just concerns in your region, health disparities, chronic illness, and what people have termed millennial morbidities. I think that this is the era that we're in today, and what we need to address to really make sure that children are healthy and well and on their trajectory to healthy adulthood. And Victor Zhao has talked about the triple existential threats to society today: pandemics, racism, climate change. These are all the issues that we need to be thinking about if we're going to keep children well and healthy. Demographers, though, were really talking about a potential decline in life expectancy in the United States in the 21st century. And this was from 2005. And they said that unless effective population level interventions to reduce obesity, and they were just talking about obesity, are developed, the steady rise in life expectancy may soon come to an end. And the youth of today may on average live less healthy and possibly even shorter lives than their parents. This is not the legacy we want to leave our kids, but this is what we're seeing today. So what are some of the drivers of pediatrics post-pandemic? And I think that this diagram, I think, is really how we need to be thinking about where we're going in the future. Family and child health needs, I think, needs to really drive this. And oftentimes we're talking about what makes money and, you know, what we should be doing. But obviously family and child health needs to drive this. We have tons of scientific, cutting edge scientific advances, and that's going to change healthcare, and we'll touch on that briefly. And then health system changes and financing within our health system. So going back to life expectancy, I think we all know that US life expectancy at birth is actually on the decline in the United States. Not, if you compare it to other countries, that's not the case, even though there was a blip with the pandemic, but we were on a decline prior to the pandemic. So 2014 to 18 was the longest consecutive decline in American lifespan at birth since 1915 to 1918, which included World War I and the Spanish flu pandemic. And why is that? Thoughts on why that is? It's really what people have talked about, the diseases of despair that have really soared here. This is suicide. This is substance use that has really led to a decrease in life expectancy before COVID. And then we had COVID with the life expectancy dropping by 2.1 to 6.6 years. So this is what you see in life expectancy across OECD countries. And I know there's a lot on this slide, but you can see the United States there at the end. And we're along with Bulgaria and Romania and the Slovak Republic and having the greatest drop in life expectancy. We are seeing some improvement, but we saw a big drop in life expectancy in addition to the diseases of despair that we continue to see. And we're seeing this in kids, and this is the new crisis in increasing mortality in children and adolescents. And you can see that upswing in mortality. And again, it's suicide, homicide, poisoning, and again, diseases of despair. So why this despair and how do we address this? So, you know, I think we all know that improving life expectancy starts early in the life course. We can, you know, increase the life expectancy of a 75-year-old to maybe 80, and that's 5 years addition. We save the life of a child at age 5. That's, you know, 75 years that we've saved in life expectancy. But we also know that this really starts early in the life course. Obesity has its roots in childhood. We all know this as pediatricians. Addiction is a pediatric disease. Greater than 90% of adults with a substance use disorder started using during adolescence. Mental, emotional, and behavioral disorders that we see in crisis today. Half of lifetime cases start by age 14, 3/4 by age 24. And then all on adverse childhood experiences associated with physical and mental health disorders, lower education, and lower productivity in adulthood. There are early antecedents to adult disease. And this slide just shows you what the opportunity is early in the life course with psychiatric illness that starts early in life. And then on top of that, we have this health crisis of the pandemic. And I think we just saw the tip of the iceberg in the health crisis that really uncovered for us the stress, the poverty, the family instability, the discrimination and inequities that exist in our system. And that life expectancy difference that I mentioned is really here. It's really different by race and ethnicity, with that life expectancy drop being even 4.2 years in Hispanics, 4 years in Blacks, and for Native Americans, negative 6.6 years. We are seeing some rebound from this, but I think that it laid bare the fact that we have huge disparities during the COVID time, not just in infection, in hospitalizations, and also in deaths, and now on life expectancy as well. So I think we all know that we need to be thinking about what UN Secretary General Antonio Guterres said, that we must act now to strengthen the immunity of our societies against the virus of hate. And with this pandemic, I think that we have seen a true danger, but the Chinese character of crisis is danger and opportunity. And I think it's our opportunity now to really face the social and racial injustice that we continue to see. So there was a National Academy report led by Tumani Coker on addressing the long-term effects of COVID-19 pandemic on children and families. And I encourage you to take a look at this report. I find it fascinating how we've so quickly got rid of our masks, and people seem to want to just get past this pandemic and not talk about it anymore. But I think that we know that children have been greatly affected by the pandemic. And what we looked at was what are the pre-existing and ongoing societies inequities that happened during the pandemic, but then what were the direct effects, and then what were the pandemic response effects, especially of closing schools. And then how do we really think about recovery for what has happened, as well as how do we really pandemic proof in the future. So people have talked about the pandemic as being the 9/11 of Gen Z, even we have COVID babies, coronials, people have sometimes said, or quarantines. And we know that the effects on children has probably varied depending on their developmental stage. But we know that that impact has been large. And this is an article we wrote early in the pandemic talking about the multiple impacts of the pandemic. We all know the COVID morbidity mortality affected more grandparents and parents of our children, but we know the number of orphans, COVID orphans, as a result of the pandemic, numbers are quite high. We also saw MIS-C in children soon after the pandemic started. Then, of course, the community stress, the unemployment, food insecurity, education interruption, health disparities, and then the adolescent and family and child trauma, the mental and behavioral health crisis that started before the pandemic, but certainly was worsened, and continuing violence. And then other COVID consequences under immunization and the continued vaccine hesitancy that has occurred, obesity, stress on Medicaid, and ones that we didn't talk about but should have remembered from past pandemics, a lot of misinformation and questioning of science, which I think are some of the biggest threats that we face going forward post-pandemic. And we know this. This is the AAP and other professional organizations really declaring a national emergency in child and adolescent mental health. And 1 in 3 Cincinnati kids are struggling with mental health disorders. Obesity, this is the World Obesity Atlas, who said that by 2035, greater than 50% of the world's population will be overweight or obese, and that every country is affected and no one is on track to meet WHO targets. And that this really did worsen during the pandemic, especially among children, and may be hard to reverse. We need to figure out how we're going to invest in addressing this because the threat of this will be far higher if we fail to prevent and treat obesity. And then, of course, learning loss. With closure of schools, there was drop in math scores, in reading scores. There has been some recovery, but many are predicting that this is going to be long lasting and really affect our future workforce. But I think even more than the learning loss, this is what has really frightened me. By school absences have exploded almost everywhere. The pandemic changed families' lives and the culture of education. Our relationship with school became optional. And you can see those chronically absent, which is 10%, missing 10% of school days, has really exploded. And of course, this chronic absenteeism really varies by whether you are in a high poverty school, middle poverty school, or low poverty school, with high poverty schools having chronic absenteeism rates of 36%, which is really frightening. And then poverty rates. And this is poverty rates by race and Hispanic origin. You can see that there was a dip when we did have pandemic supports and the child tax credit. There was a dip in child poverty, but of course, many of those supports during the pandemic have expired, and we're seeing an increase again in poverty rates with big disparity by race and Hispanic origin. So, and just to remind you, that's the poverty level of $30,000 for a family of 4, which really is not what you can live on. So, a question for you: the U.S. minimum wage. What's the U.S. minimum wage? Anyone know? It's actually it's less than $7.50 an hour, and there are many states that still have the federal minimum wage, and that's $14,790 a year. That federal minimum wage has been since 2009. People know the California minimum wage? It's higher, which is good, and it's needed, but still, it's $32,640 a year. And that is really tough for a family of 4, I think we know, to live on in the state of California, or really probably everywhere. Christoph and Wudun have said that if the federal minimum wage had kept pace with inflation and productivity since '68, it would now be over $22 an hour, not $7.25. And that's one reason why 76% of adults expect their children's lives to be worse than their own. And we have the research, we have the evidence that shows that increased family income through minimum wage itself has positive effects on child health. A $1 increase in the federal minimum wage is associated with a reduction in violent behavior in the most vulnerable families and decreased low birth weight and postneonatal mortality. I think that we know what we need to do to improve health for many children in this country. And the United States has the highest poverty rate compared to other developed countries, and that's really correlated very well with public spending on families and children as a percent of GDP here. As you can see, the United States has the lowest percent of GDP spending on families and children compared to other OECD countries. And then I show this chart on poverty rates for children and the elderly, just to show you that we can do something about poverty. Oftentimes people say, well, you know, what are we going to do about poverty? We can't do anything about it. But you can see here that the elderly had higher poverty rates, 35% in the late 1950s. And with policy interventions, the War on Poverty and Medicare, we were able to reduce the poverty rate among the elderly. You can see the child poverty rate has not really improved over time. But I would just say that there are things that we can do. And the National Academy did put out a report on a roadmap to reducing child poverty, on how to cut child poverty in half in a decade. And they gave very specific ideas on how it could be done, with many economists contributing to that report. So I think it can be done. It's an issue of whether we as a country have the commitment to do it. So moving on to wealth, how much liquid wealth, financial assets can be quickly turned into cash do you have? How much wealth do you have? How much money do you have in the bank? How many assets? So according to the Board of Governors of the Federal Reserve in 2022, the wealth of the typical Black family was what percent of the typical white family? Thoughts on this? It's actually, if you guess the lowest on this list, it's 15%. And those are the numbers for you. And obviously, if you don't have money in the bank and you know, you have your car breaks down, you have a health problem, it's gonna be a problem for you to manage. And we know that wealth surged in the pandemic, but debt endures for poor Black and Hispanic families. So again, really increasing inequities and in income, and really the impact on many areas of the pandemic have really hit our marginalized communities in a larger way. I don't know how many people were at the Pediatric Academic Society's meeting a couple of weeks ago, but Brian Stevenson was an amazing speaker, and I really liked the quote where he said, "The opposite of poverty is not wealth, the opposite of poverty is justice." So finally, I wanted to mention the US Census Bureau tipping point. I think we all heard about this when the Census Bureau confirmed that minority births in the United States outnumbered white births for the first time in the year that ended in 2011. And we have greater diversity in our child population, and we're at the cutting edge and the leading edge of diversity, which I think is wonderful because I think diversity enriches all of us, but not if we have those disparities in income and wealth related to it. So I always showed this cartoon that says, obviously a stereotype, non-white babies now outnumber white babies in America for the first time, and appropriately he says second. And I think it just points out to all of us how racial disparities continue to affect our Native American population, and we need to really address this if we're going to address the health of our nation. Finally, on immigrants, this is the percentage of US children who are immigrants, and it's been pretty stable. About a quarter of our children are immigrant children, foreign born themselves, or at least one foreign born parent. And if you look at the growth in the number of US children, it's been immigrant children that really have increased, allowed us to have any increase in all children, in the population of children. And that increase in population of children has been over time. You can see 1994 to 2022. If we didn't have immigrant children, we would have a loss of the child population, a large loss of the child population overall. We are a land of immigrants. What if we had no immigration? I think we'd see a real drop overall in the number of children. I think we'd have a lot of employment problems because a lot of our immigrants are employed in areas that others don't want those jobs. And they're often, kind of these faceless children that we're talking about when we're talking about immigration in this country. But we really are a country of immigrants and rely on our immigrant families and should be supporting them and proud of them. And that's me. I was a child of an immigrant Chinese family. And that's me doing my favorite things, eating a cookie and writing. So the future of pediatrics, we've talked about child and family health needs, COVID and the consequences, millennial morbidities, health inequities. What about cutting edge scientific advances? We've mentioned the history of medical progress. In the 19th centuries, we were just treating symptoms because we didn't know pathophysiology. In the 20th century, we began treating diseases. And in the 21st century, Elias Zerhouni, our previous NIH director, talked about the 4 Ps: predictive, preemptive, participatory, and personalized care, really because of scientific progress and sequencing the genome. And we know this, the cost of sequencing the genome has really plummeted, and the number of phenotypes with a known molecular basis has really increased. And you can't go and read an article these days about the discovery of some gene polymorphism or epigenetics that is affecting our health. So this is Elias Zerhouni's graph that really shows how we've been on this curative treatment symptom management part of this curve on disease burden. But that with molecular preemption, we're shifting that curve to the left, and we have the opportunity to improve health because we're on not the steep part of the curve, but prevent disease and preempt disease and really potentially save cost. So again, early in the life course, we're going to potentially know the whole genome sequencing of a fetus. We could get that along with the ultrasound and really have some prediction of what's in store for the health of that child long-term. So I think that's very similar to, this is my favorite graph on the life course view of health risk. Again, we want to be on that low trajectory disease burden part of the graph, the green part. And we know early in the life course, there's a lot of plasticity. There's a lot of plasticity of the brain, and that decreases, as we all know, as we get older. It's more rehabilitation than real regeneration. We also know there are detrimental effects of adversities and lifestyle challenges, and probably those effects accumulate across the life course and cause more potential disease burden from it. In this graph, they talk about how adult screening may be too late to really reduce risk. You're already on that steep part of the curve. Maybe you can have limited intervention. That for affected adults, interventions have limited effect. It may be, 2, 3, 4 years of life that you're gonna increase life expectancy. But the opportunity is really in mothers and infants. An effective point to intervene. We're learning more and more about biomarkers of risk and the potential to prevent disease in childhood and adolescence, and to really intervene. I think the other part about pediatrics is that we know that we're also working to improve the health of children who are going to be the future child bearers and part of that human reproductive cycle. And that in addition to that human reproductive cycle, we are learning more about heritable, genetic, epigenetic, and environmental factors that can affect the risk of ill health in the next generation. So we have all the opportunity, I think, early in the life course, and we need to be thinking about the life course and emphasizing how important children and children are in setting the foundation for lifelong health. So Atul Gawande has said that in this era of advancing information, it will become evident that for everyone, life is a pre-existing condition waiting to happen. So we talked about the 4 Ps: predictive, preemptive, participatory, personalized. I think pediatrics and prenatal are 2 more Ps that we need to add to it, because that's when the opportunity is to really prevent, to really do all those 4 Ps that we just talked about. And I won't go into this, but we know precision pediatrics is the future. And this is just 1 month's worth of journal articles talking about a whole range of opportunities. One of these is 5 and 7 infants in whom genetic disease were identified post-mortem. Death might have been avoided had whole genome sequencing been performed. I think we have a huge opportunity in pediatrics and the genomics revolution. So what are the next 7 great achievements in pediatric research? We actually did talk about that. This says we don't use a crystal ball anymore, we just Google you. But we talked about more immunizations. Actually, we wrote this before the pandemic. So more immunizations, obviously, I think the COVID pandemic showed us how important immunizations are. And other areas, cancer immunotherapy, genomic discoveries, big life course data, and tech. And I think we all know that tech is going to be changing how we work and potentially also predicting disease later. Understanding the interaction of biology, physical, and the social environment. Quality improvement, implementation and dissemination research to achieve global health equity. And we can discuss lots of other areas of research that we know will be making a difference when we talk about this 40 years from now. NIH talked about the lessons they learned from the pandemic, and they talked about how rapid science success in vaccines, therapeutics, and diagnostics, it really was tremendous what was done during that relatively short period of time. That they talk about the need to continue to support investment in basic and applied research to improve our science communications. And that's one area that I think we will talk about more. And we need sustained learning and constant preparation and advanced readiness for the next pandemic that we know will be coming. So it's cutting edge scientific advances, genomics, epigenetics, new vaccines, developmental origins of health and disease, science communication. And then we live, how about health system changes? So this is the future scan of how we have been in this first curve of this model, of a value-based model in healthcare delivery. We've been in fee-for-service acute care paradigm, that we've been moving to this second curve of value-based care, where we're paid now more on our quality metrics and paying a lot more attention to safety, patient satisfaction, and cost. And many say that we're really moving to this third curve of global payment that's tied to population health, that we're really emphasizing now the importance of wellness, prevention, management of chronic disease, more discussion of accountable care organizations, and pay for performance that's tied to quality metrics. I don't know how much you're seeing this here in California, but as you know, CMS has said that they really want to move largely to value-based care and global payment in the future. And this is an article in the New York Times Magazine that says, if our beds are filled, it means we failed. That we need to be really thinking not about illness, but really about health and well-being and preventing kids from needing our hospital beds. And it's really talking about how medicine is changing as well. So this is AI versus the MD. We know that AI is going to change how we work. The robot will see you now. We need to also be preparing for the technologic changes that are happening in the way that we do our work. This is my favorite AI graph. I don't know if people have seen this one where, they have now learned that the algorithms, computer algorithms can differentiate the puffy or the muffin better than humans can. And I think that this will change what we do in a lot of our work in the future. And our children, as we all know, live in a digital world. I'm always impressed by how adaptable they are to the changes in our technological world. But the good and the bad, I think that they're going to be leading us in this technological world. How do we protect them from the bad parts, but also encourage their innovation for the future? So we've been through a lot here and talking about child and family health needs, cutting edge scientific advances, and health system changes. Where do we go from here? What are our windows of opportunity? How do we really lead the change that we need to see for the sake of children? In the Academy report I mentioned, we talked about how children are often the last to be protected and the longest to be affected. We know that the directive effect of the pandemic, as well as the response, have been a major adverse childhood experience for the child and for the family, and that there are long-lasting effects and life course impact of the pandemic that we can't forget and we really need to work on. That low-income and minoritized communities face the greatest adversity during the pandemic and obviously before, and we really need to help children and families recover now and pandemic-proof for the future. So just really talking about health equity, this is one of my favorite depictions of what reality is, what equality is when everyone gets the same supports for equal treatment, everybody gets that same crate to stand on. Equity is when everyone gets the support they need, which produces equity. And justice is when you take down that barrier altogether and everybody gets to participate. So I do think we do have a window of opportunity. Richard Besser has said that medicine is a privileged window. I believe that to be true. We have the privilege to work closely with families. We have the privilege to be leaders in our communities and get the respect from our communities. And we have contact with families. We have the privilege to work with children and influence their well-being early and throughout their life course and potentially intergenerationally. And we know, but I also do think we do know what works. We just need to do the advocacy to make sure that we do what is needed. So what are some of the windows of opportunity in practice? So we need to diagnose and address COVID impacts and health disparities in your community. We need to look at our data, identify hotspots. We need to measure race, ethnicity, SES language in QI and in research, and really take seriously a look at this and understand the reasons and then the pathways and to act on it. I think more and more we are doing this. It's taken us quite a long time, but we need to face up to the fact that there are disparities and then make sure that we're acting. We need to co-create and design with families and communities to improve health and well-being. And this is just one article that looked at the priorities of low-income urban residents for interventions to address social determinants of health. And they came up with health insurance needs, housing vouchers, dental care, and job training. When we've asked in our clinics, families talk about quality childcare and education and opportunities for their children, safe homes and neighborhoods, and mental health. And these are the areas that I think we need to work with communities to really address for families. Second, I think we need to diagnose and address COVID impacts and health disparities in our clinical encounters. I think we are starting to do this in many different areas of healthcare, screen for social determinants during clinic visits, and really try to address the needs that are raised. But I think we need to go further, and we need to design new models to transform population health. Carolyn Clancy has talked about how healthcare needs to provide the right care, the right patient, the right time, the right place, and every time. So I think when we talk about the right care, I think it's really addressing population health, not just individual health, the socio-political determinants, behavioral health, and go upstream. A couple of examples here are at Hopkins, our Harriet Lane Clinic really was built to be a family-centered pediatric health home, that it really addressed many of the social determinants of health. So providing medical, dental, and mental health in one place, nutrition, lactation services in a food pantry, developmental assessments, literacy programs, educational screening. We had a family needs screening and health leads help desk that would work directly with families on the family needs, screening for intimate partner violence, safety, depression, and maternal depression, including services for families, family planning services, career planning, specialty case management. We had a youth fitness circle to address the obesity issue, legal advocacy, injury prevention center, all led by our community advisory board to really provide one-stop shopping for the needs of families in this community. At Cincinnati Children's, legal advocacy has been a large part of what we do. And this study by Andy Beck and Rob Kahn really talked about how it discovered how Cincinnati Children's reduced hospital admissions by 38% by offering legal help to remedy poor living situations. And this is part of our care right now. And Rob Kahn said if this were a pill that demonstrated a 38% reduction in hospitalization, every pharmaceutical company in the country would be going after it. Every healthcare payer would be figuring out how to cover it. I think that that's a very true statement, but unfortunately, it's not exactly what's happening. But these are the types of interventions I think we need to be thinking about. So it's not just caring for that individual patient anymore, it's also providing them the care coordination, disease management, and care management, but also thinking about the population health and wellness of families in our communities. I think in addition to kind of one-stop shopping, another is really moving from a reactive to a proactive system of care. And this is at Cincinnati Children's, the mental health care that we provide, that at the top, you're talking about inpatient beds and 24-hour psychiatry management. And we have 130 pediatric mental health beds. But we know that that's not going to be the solution. We need to be going upstream, which is actually moving down this triangle, where we have partial hospital programs, crisis care programs, a lot of specialist outpatient mental and behavioral health management, but also integrating behavioral health programs in the community and school. So we are really doing a lot of training programs of primary care providers and other providers in the community to try to address mental health concerns that arise before they need to go up this triangle to inpatient care. And then really working in the home on parenting programs and maternal and family mental health issues, home visitation programs, to really, again, moving from a reactive to a proactive system and going upstream. So I think the right care we've talked about, addressing population health, social political determinants, behavioral health, going upstream. I think the right patient, the right time. I think we need to think about addressing populations in particular need or communities in particular need, family health, and transition to adulthood. So a few quick examples here. We in Baltimore had a large and growing Latino community that had a lot of strengths in their community, but also had some unique health needs. So really addressing their specific needs hand in hand with the community, addressing their needs through Central Soul. Another project that we worked on was really focusing on family health. And one question in primary care I think is so important to a family is how large of a family do you wish to have? In our Harriet Lane Clinic, we asked new mothers about their family, their own health, and moms in that clinic this was a pretty young group of moms, whether they had a primary care provider for themselves. Most of them did not. Did they have insurance after pregnancy? Most of them did not. And I think a lot of them didn't even know they wouldn't have insurance after pregnancy. We asked if it was a planned pregnancy. Here they are with their new baby. The vast majority said it was an unplanned pregnancy. And we asked if they had an interest in having their primary care provided by the clinician for their child, and the vast majority said yes. So we really did do a preconception women's health and pediatrics study, a randomized trial of a women's health screener and brief intervention with mothers bringing their children in for well child care in 4 different sites. And we really addressed the mom's health needs her access, family planning, folate intake, depression, and IPV. And we're able to demonstrate that we could decrease mom's cigarette smoking, increase her folate vitamin use, and increase her knowledge around optimal interconceptual family planning. So I think that these are the kinds of things we need to be thinking about in expanding our focus. And another quick example, promoting healthy futures, really enhancing transition to adulthood. We're seeing all these young adolescents and adults, some of them that don't have the supports to think about a future career. And so this is a randomized trial of a motivational interviewing coaching intervention with clinic patients in a low-income clinic where we provided a career coach, and we're able to see increased career efficacy in those in the intervention group. And we weren't really expecting health outcomes, but found that we were able to decrease marijuana use and reported fighting. So we've talked about the right care, the right patient, the right time, and the right place. We need to also go beyond the office and really integrate our services in the community. Home visitation, patient navigators, school health, and community learning networks. The World Health Organization has talked about how the single most effective way to improve health and reduce disparities is to invest in helping young people reach their academic potential. And we know that children's health and educational success are really interconnected. So this work we did in a couple of schools where we were really focusing on academic achievement and health, had full service school clinic, had mental health and chronic illness programs, wellness programs and school health campaigns and screening programs, nutritional and physical activity, school health curriculum, and then really also focused on parents and teachers because if they're not healthy and well, they're not going to be able to support kids. And there's lots of research on different models, but in the model that we looked at, we were able to reduce chronic absenteeism. We want kids in school. We don't want them to be absent. Reduce emergency department utilization, increase immunization rates, screened for vision, dental, BMI, and service, and gave them services and glasses if they needed glasses. School-based health and clinic enrollees had greater health and educational risk, but more growth in math and reading achievement and less absenteeism. So we actually were able to demonstrate increased achievement as well. And then cost effectiveness. For every dollar invested, it returned more than $4.20 of social benefit. I think schools is an area that we could really get to kids and is an area that we should be focusing on to improve child health. And then finally, at Cincinnati Children's, we have an All Children Thrive Learning Network. We know that we're not going to fix the issues that a lot of families have by ourselves in our offices, but we really need to collaborate with other community entities. And you see many of those entities here. And through a learning network in the Cincinnati area, working closely together with community agencies, having equity-focused goals, having improvement methods, sharing best practices, having strategic partnerships with families, and a relentless focus on results and data, showing those results, we have been able to really have this learning network make an impact in many different areas that with our community partnerships shown here. And it's been really great to work with our community partnerships. We've learned a lot, and this continued QI process and looking at data together has really had an impact on health. So we've talked about right care, right patient, right time, right place, and of course, it should be every time, every child. The window of opportunity is also that we become literate on health literacy, culturally and linguistically competent care, and anti-racism. So encourage people to utilize health literacy toolkits that exist to really talk about whether, really analyze whether your practices and your healthcare settings are really accessible for people that have lower health literacy. Of course, eliminate language barriers and delve into your own unconscious biases and take the implicit association test. But finally, I want to spend a little time on what we need to do in advocacy, because I think it's really advocacy for institutional and public policies that support children, that support science, and that support health equity that we really need to focus on. And here, I think we need to promote anchor institution policies. We need to address the political determinants of health and focus on science communication and advocacy. So how can this article on how humanity gave itself an extra life, it talked about how the average human lifespan doubled. How did we do it? They say that science mattered, but so did activism. And I think that we need to be more active. We know that there's a war on science right now, a lot of misinformation. At the same time, we also know that, this report says, why aren't kids a policy priority? The cultural mindsets and attitudes that keep kids off the public agenda. So another question for you. According to Isaac and Schroeder's review of US public health successes like smoking, lead poisoning, auto safety, which of the following was not a key factor? Any thoughts on this one? It was not the leadership of the academic community. It was highly credible scientific evidence and really having the research that we're all working on. It was strong advocates, which is what we are. It was partnership with media for public awareness and discussion. And we need to be, I think, more publicly out there on what we need to be doing for child health and law and regulation. And I don't know how many people have seen Daniel Dawes' book on the political determinants of health, but what he argues, and I would totally agree with, is that we have these social determinants of health, but they are really rooted in political determinants of health and policies that exist that have allowed children to live in poverty and to have allowed inequities. So there's this article talked about the role of hospitals and universities in addressing social determinants of health. I think there's much that our institutions can do to support the local workforce, a living wage, pipeline for jobs, support community-owned and minority-owned businesses, addressing health-related social needs in the community with community engagement, food programs, environmental stewardship. I think the environmental stewardship is a huge part of this as well. And then, of course, equity as a strategic priority. And this is the big model, and I know you can't read all of this here, of the political determinants of health. It includes voting there, it includes political activity and running for office and really talking about the areas of advocacy that we know we need to do. What do you have to stop heartburn, nausea, sleeplessness, and headaches? Have you tried voting? I'm not sure that's going to do it totally, but that's what we need to do. This talks about spending on children, and you can see that blue at the bottom is the spending on children. It's expected to decline again and fall below spending on interest payments on the debt in 2024. We do not spend on children and families like we need to. And again, I showed you why aren't kids a policy priority. I think we need to be thinking about how we message the importance of children and the importance of science. I don't know if people know Frameworks Institute. They are cultural linguists that really focus on messaging and how do we word our messages in a way that resonates with the public. And here's a few of their reports. Changing the child obesity conversation, reframing children's mental health to make it more salient. There are many societal gains in investing in children. We have a declining population of healthy children in the United States. We need to be talking about this and talking about the importance of investing to protect economic and national security, to live up to our national values and moral imperative, to leverage the prevention potential in emerging science like genetics, to address early antecedents of adult health that's going to pay off later, to protect our parent workforce productivity. If you have sick kids, you're not going to have working parents. And our kids are our future caretakers of a growing elderly population. They're the future child bearers in a time of decreasing fertility. As a nation, we need to be really addressing this now. A couple of reports that have come out, this is the Congressional Budget Office report that said Medicaid enrollment during childhood was shown to increase earnings in adulthood. Not terribly surprising, but they had to prove it. And that the long-term effects of Medicaid spending on children could offset half or more of the program's initial outlays. These are long-term studies that need to be done that shows that investing in children does have long-term payoff. I don't know if people saw this report, 77% of American youth can't qualify for military service because of their health conditions. This has been increasing, and 3 branches of the military did not meet their recruitment goals for the first time last year because children are not healthy enough. So I've talked about many ways that I think we do have a window of opportunity, and I think it's an imperative for us to address the issues of our declining health, the declining health of our child population. And I've often talked about the wisdom, the will, and the wallet. I think we have the wisdom on what needs to be done to address child health. I think we spend in this country a lot. We have a big wallet for healthcare in this country and other priorities, but I don't think that that wallet is spent on kids as it should. And I think we're lacking the political will to really be leaders on behalf of kids and families. So last question, children less than 18 make up 22% of the US population. What share of the federal budget is spent on children? It's actually around 10%. And what share of US healthcare spending is spent on children less than 20 years? It's about 10.7%. It's kind of, as Paul Weiss said, budget dust. So it's not a lot. And even though it's 10% of all spending, children are 100% of our future. And I think that we need to be stronger advocates to make sure that children are at the center of our policies in the United States to really improve child well-being and our nation's well-being. So with that, I welcome your thoughts and your comments on what we need to be doing to improve the health of children.
Oh, Tina, amazing. Thank you so much for that powerful talk. I think one of the challenges that we have is in that one slide you indicated, a dollar spent was a $4.20 return in general. We have a wrong pocket problem in that when we invest in one sector, the return is in another. What creative ways have you seen or heard in terms of how we can kind of cross that wrong pocket problem? Because I think that would unleash a lot of potential.
I totally agree with you. I think that we have a wrong pocket problem in that if we save, improve the health of children, we're improving the payoff in healthcare and education and social services and juvenile justice. I think our other problem is that our return on investment is long-term. We're not, if we invest in, childhood obesity interventions, the payoff from that is, probably when they are adults and with less obesity. So I think we need to do more cross-sector integration of our work. I think that's really hard because we are siloed and our finances are siloed across these sectors. So I think we need to work on how we work with our community, but then also how do we try to braid some of that funding together so that we share the same goals, but we're paid in such different ways. I think there are a few examples of kind of braided and blended funding across sectors, but they're still pretty early. So some places are putting together a child trust fund and funding together. We've encouraged some of our philanthropic funders to actually fund cross-sector work. And so we have some grants that are specifically written that some of this has to go to the school system, but come through Children's Hospital. I think it's a major problem in what we're seeing in child health today, but we need to work across sectors.
Okay, thank you. So we have a lot of good questions online. Is there any evidence that the anti-vax movement has lowered life expectancy by increasing childhood mortality?
So great question. And I see you have Peter Hotez coming next week. And he was actually at Cincinnati Children's last week. And he gave a great talk, and we'll talk a lot about the anti-vax movement. I'm not sure that's been modeled out. He would probably be the best person to answer that, of how much vaccine hesitancy has what the outcomes are. But I think it's not hard to model out.
All right, we will save that question for next week. It is my understanding that some children's hospitals in Ohio were receiving capitated payment for a large segment of their pediatric patients from a consortium of insurance companies. Is that true for Cincinnati? Has that approach to reimbursement incentivized paying for more basic drivers of health as opposed to more expensive hospital-based care?
So I could talk about this question for a long time. So in Ohio, a lot of our Medicaid managed care providers are in contract with Cincinnati Children's as well as Nationwide and other hospitals to give a per patient per month payment to us in the hopes that we will spend that money wisely and incentivize us to work on child well-being in the community and keeping people out of the hospital. So I think that it has had an impact on shifting the incentives and the priorities of our hospitals to prevention and community-based activities and equity-based activities. And so the state has been very active in that, and it's been, it started with one insurer, and it's spreading to other insurers as well. I was previously in Maryland, where there is a unique payment system of global budget caps for hospitals and a hospital rate setting commission that sets the rates for hospitals, regardless of how many patients you have and how sick they are. I think that it did shift priorities to more population health and well-being. I think an unintended consequence, which I've written about, is that it shifted the focus to adults, though, because they were trying to save money in the short term and focused really on adult short-term cost savings and did not focus on kids at all. So I think we need to be really careful with some of these new funding models.
Yeah, there's another question about, would national healthcare or universal healthcare result in more longer term thinking and more preventative measures? I'm going to guess it probably would depend, but what would you say?
I think it's how we set it. I mean,
Yeah.
The devil's in the details
Exactly.
of how we get paid.
Yeah.
in
So here's something a little bit different. So first of all, your talk was excellent, covering so much in under an hour. Do you see the importance of everyone being responsible for their own well-being, and that patients and families should be active participants in their health rather than passive recipients? What's your opinion and experience on incorporating lifestyle medicine practices for children and families?
I mean, I think that families should be active participants in their health. I mean, I think some of them, we sometimes train them not to be. So I think it will take us to help really work with families, not tell families what they need to do. So I would love to see more activation of parents in children in their health. But I think some of that's on us.
So here's a question that maybe Lisa Chamberlain or some others, we'll see if anybody knows the answer to this. What % of pediatric residents vote? I don't think anybody knows the answer to that question. Any takers? And then the next question is, what % of attendings vote?
Actually, there's a paper on that came out recently.
There is.
On
Oh,
how
good.
on the percentage of physicians that vote.
Oh, good.
And it was, from what I can remember, it was fairly high, but I got to go back to that paper. It wasn't terrible, but
it begs the question, did they break out if pediatrics is any different? I don't know, it'd be interesting. I just will give a plug that the incoming president of the American Academy of Pediatrics will be giving grand rounds on Tuesday, November 5th, which is election day. So that'll be interesting. All right, well, we are out of time. We just want to thank Dr. Cheng for joining us again today. Thank you, everybody.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.